Most people have probably heard the term chronic obstructive pulmonary disease or asthma, somewhat related diseases. COPD, chronic obstructive pulmonary disease, is generally something we think about that occurs later in life. Asthma can occur at any time. Frequently, kids can have childhood asthma and outgrow it. Then they can get recurrent return in adult. Sometimes people have asthma throughout their life. It's a hypersensitivity. It's kind of along the order of those autoimmune diseases that we talked about. There's a little bit of different component. With chronic obstructive pulmonary disease, the biggest underlying factor is reduction in the elasticity of the little balloons in our lungs, the smallest segment of the functional lung called the alveoli. So your lungs are made up of these many little tiny balloons that have an elastic component that squeezes the air back out of the lung. And it's where gas exchange occurs from inside the lung into the blood vessel, which the capillary bed surrounds the little alveoli, so that oxygen is brought into the lung. The oxygen transfers across the single cell membrane of the alveoli into the capillary, which is the smallest unit of the blood vessel, and then it's carried to the heart and then out to the body. The carbon dioxide that was brought back by the capillary has to be removed, so it transfers from an area of high concentration in the capillary to the lung where there's lower concentration, and then the alveoli squeezes down as we exhale and the gas is expelled. Carbon dioxide leaves the body, oxygen is brought in through this mechanism. Now, how we move air in and out of our lungs has a couple of components. One component is muscular. We expand our chest by making our ribs spread out through contraction of our intercostal muscles. Our diaphragm drops down. That's a muscle that separates the chest cavity from the abdominal cavity. That increases the volume of our lung space and passively sucks the lungs into a larger space, stretching out those little balloons, those alveoli, and bringing air into them for that process to occur. Asthma and COPD affect this process. COPD occurs because of destruction of the elastic tissue, okay? So normally when we relax and our chest reduces its expansion and our diaphragm comes back up, what we see happen is that balloon squeezes the air back out of the lung. We're all losing elastic tissue. You can say, I've got some wrinkles here at 58 years old. My skin's not as elastic as it once was. So as we age, our elastic tissue is declining, and that's happening in our lungs. Now, if you want to accelerate this process rapidly, you can do something like smoke cigarettes, which rapidly deteriorates the elastic tissue in the lungs and generates this diagnosis of chronic obstructive pulmonary disease. What happens is air gets trapped in the lungs and we can no longer move as much air, and it happens because of this process. Now, in order to get the air out, we have to forcibly squeeze it out with our muscular contractions, and the pressure inside the thoracic cavity, the chest cavity, exceeds the pressure in the small little airways that exit the little balloons, the alveoli. So at some point, because we're pushing from outside instead of the balloon squeezing, we shut off the airway, and now the air gets trapped in the balloon. So we lose ventilatory capacity. We can't move as much air in and out. That's chronic obstructive pulmonary disease. There's a component, a bronchitis component, where particularly if you smoke, you have a lot of inflammation and airway secretions that further narrow that tiny air channel and make that process happen even sooner. And that's where asthma also comes in. Asthma is the reactive component. Now, these little channels that connect to the balloon and lead to the bigger airways that ultimately, come up to our big bronchi and then our trachea and the air comes out. These little channels are lined by smooth muscle. And that smooth muscle has a certain amount of reactivity. It can contract and constrict. And in asthma, there's a tendency for this to happen, and it typically happens when there is some sort of insult that triggers this squeezing of the small airways. So we call asthma reactive airway disease, and some people are deathly allergic to certain things, and they might, it can happen from a bee sting because of a kind of a systemic allergic reaction, or it can happen when they breathe in certain things like maybe even a perfume or something, or cat hair or dander. So the asthma component is kind of a reactive allergic component. There's generally a lot of crossover. I mean, people who have COPD frequently also have some reactive component. And in the treatment of these disorders, we try to affect two major components. One, the reactive component, and we do that with medicines like bronchodilators. Albuterol, which is a sympathomimetic, tends to relax the smooth muscle in the airways and can combat this tendency to squeeze down. And then the second component is to try to reduce inflammation. And most commonly, the medications that are employed, at least in the emergency setting, how I've rescued people many, many times in my career as an ER physician, was to use bronchodilator therapy, albuterol, often delivered by continuous nebulization, so they just keep breathing it in, and powerful steroids to reverse the inflammation on the inside of the airway, to try to keep that channel as open as possible to let whatever squeeze we have left in that balloon push as much air out as possible and create as much air exchange so that ventilation and physiology can continue. The elastic component, you're not getting that back. So, those of you that smoke need to realize that we're all on this slope where our elastic tissue is declining, and some of us have genetic predisposition to decline faster than others. As with everything, there's genetics. But if you smoke, you are steepening the loss of that elastic tissue. You're accelerating the time when you're going to get COPD. If you live to be 100 on planet Earth with the pollutants and things that are damaging our system, you will have some COPD. It may not be that clinically apparent, but your pulmonary function is not going to be what it was when you were 20. So the point is, let's not do anything to hasten this. And I guess the why of the talk is so you would understand a little bit about asthma, COPD, how it's basically treated in the acute setting. There are medications that we use for long-term treatment. Inhaled steroids can be helpful in relieving the chronic inflammation that some asthmatics and COPDers have without subjecting the person to chronic systemic steroids, which can have a lot of negative side effects. There are certain medications, mast cell inhibitors and things that do reduce some of the molecules that circulate that increase this hypersensitivity and reactive airway disease, and some people get on those medicines chronically. But here again, you want to, particularly with asthma, you want to reduce the amount of unnecessary irritants, so avoidance of the allergens, and you want to reduce that autoimmune component by having a clean, healthy diet that doesn't have your immune system hyperactive. And with COPD, you want to remove the insults that are going to further damage that elastic tissue. So I hope that helps you have a little bit better understanding of just exactly what's going on with these two common chronic lung conditions. And we'll be moving on. And just don't forget that the more you learn, the more you can expect success. Thank you.